This is working very well. So far, we have to start at 2 o'clock. Okay.
Can we get the slides up, please?
Yes, Usher is giving us the option. Give me a minute. Can everyone see the slides?
Mm-hmm.
Surely.
Yes, we can.
Yes, we can see.
Okay, thank you.
Dr. Humayun Naqvi, Assalamu alaikum.
So it's 2 minutes
Walaikum
after.
assalam. Walaikum assalam. Jazakallah. So nice to hear you.
Okay. Kiran, do you want to start? And I would ask everyone to go on mute for now. until we have room to ask questions. Thank you. Kiran.
Okay, yes. Give me a second. So, just a minute. So, Assalamu alaikum, everyone. My name is Kiran Ijaz, and on behalf of Imamiya Medics International Academic Wing, I welcome you to this annual webinar on Ramadan fasting and diabetes. We'll start our session today with a panel discussion with our experts, and later on we'll open the floor to for Q&A. I would request all of you to submit your questions to us via the chat option, or you can ask them directly by unmuting and speaking in the meeting. I will also request you not to share your personal treatment plans. This session is actually meant to convey an overall understanding of the topic. And for your unique treatment plans, we'll ask you to consult your private physician privately. Can I request everyone to mute their mics, please?
Kiran, you can mute all except Dr. Arshad Qayyumi. You can mute yourself. As a host, you can mute all other except the speaker.
Yes, we'll do that. So moving on, the experts joining us today for this webinar are Doctors Arshad Qayyumi, Dr. Ishaq Arastu, Dr. Shahid Qayyumi, and Sister Wahida Karamali. I'll introduce Dr. Ishaq Arastu first. He is board certified in internal medicine and endocrinology. He serves as an associate professor at Temple University and Katz School of Medicine. He serves the community via his endocrine practice in Bethlehem, Pennsylvania. Then Dr. Wahida Karamali is a doctor of public health and a registered nutritionist. She works at the Columbia University in New York as a special research scientist. She is also the associate editor at the Journal of Clinical Lipidology. Dr. Shahid Qayyumi is a clinical cardiologist at Staten Island University Hospital in New York, which is affiliated with Northwell Health. Dr. Arshad Qayyumi will be moderating the expert panel discussion. He is well known for leading the IMI academic wing. Professor Qayyumi is the cardiologist at Emory University in Atlanta, Georgia. He is also the director of Emory Clinical Cardiovascular Research Institute. After this brief introduction of our panelists, I request Dr. Arshad Qayyumi to start the expert panel discussion, please. Thank you.
Thank you, Kiran. And welcome everyone. Assalamu alaikum. Bismillahir Rahmanir Rahim. As you know, we are going to discuss diabetes and what people with diabetes do during Ramadan. And this is a vast subject, of course, and we don't expect to have time to cover everything, but we want to cover some important things, particularly for the rest of the population who are not in the medical field, and also give you the opportunity to ask questions once the expert panel has made their presentation. And the reason for picking on diabetes is for several reasons. One is that there are now estimated to be 35 million people in the US who have diabetes. That's 11% or so of the population, and perhaps another 2% don't know they have it because they haven't been tested and diagnosed. And even though it is 11% in the general population, people of South Asian origin in particular and of Middle Eastern origin have very high incidence of diabetes. It's estimated that South Asians have about 23% incidence or prevalence of diabetes. So that's a lot of people, and it affects them during Ramadan. Next slide, please. And as you know, Allah subhanahu wa ta'ala has instructed us through the Quran, and this is the Surah Baqarah, that you can see here, but translated, he's exhorting us to fast during the period of Ramadan. But it also says in the same surah that if anyone is ill or is on a journey, the prescribed period should be made up by days later. And Allah intends every facility for you. He does not want you to put up with difficulties. So there is an allowance, if you like, made for illness and conditions that may make it hazardous to fast. And that's what we are really here to discuss and to focus on, and how people with diabetes particularly should cope with Ramadan. And so what we are going to do is to start off with each of our expert panelists, and we'll pose some questions to them, and they'll use some specific slides to make their points. And as I said, after that, we'll have Q&A. So I'll start off with Dr. Ishaq Arastu. Next slide, please. If you could tell us, Dr. Arastu, what is diabetes? How would you define it, and how do you understand it? How does it get diagnosed? Thank you. We cannot hear you if you are. You need to unmute, please. It's up by that's it.
Assalamu alaikum, everybody. Thank you, Arshad. Diabetes means sugar excess in the bloodstream or in the urine. The word diabetes mellitus is because there is sweet urine. Shakkar ki bimari is the word that in Urdu we use. The sugar normally is very essential for our existence in the form of glucose in the bloodstream. Without that, we cannot generate our day-to-day activities inside the cells and in physical performance. So it's the fuel that our body needs. But if there is too much of that fuel and it is not going where it belongs, then it causes complications called complications of diabetes. So generally, we consider that if a blood sugar is over 126, that you have diabetes, hyperglycemia. So that is the general definition. Now, the reason why you have a difficulty with maintaining the sugar is because in diabetes, there's either an inefficient way in which the body can harness insulin, or there is actually an absolute deficiency or reduction in the insulin because the cells that make insulin, called the beta cells, are destroyed by an autoimmune process. So there are two different ways in which diabetes can occur. There are other forms of diabetes which may not be so common as the one without insulin and one with an inefficient insulin function. So insulin is a hormone that the pancreas produces from the cells called the beta cells. And that is where the center of action of diabetes seems to lie. There are other hormones also that co-regulate the glucose with the sugar, with the balancing of the sugar. And those are called the co-regulatory or the counter-regulatory hormones. And those are made by the pancreas, and some are made by the pituitary and adrenal gland. When we eat sugar-containing foods called carbohydrates, that is broken down in the body to molecules called glucose, and that is essential. That is where our body is capable of converting this glucose into energy units called ATP and ADP. So anyway, carbohydrates can do that. But the other foods, the proteins and the fats, can eventually be harnessed also to produce this substance called glucose. In diabetes, the body itself make the proper use of cannot use the glucose properly, and therefore the glucose builds up. When the sugar builds up in the bloodstream, then you have to excrete it out. Otherwise, it can become a toxic substance. Then that is called glucose toxicity. And when the glucose exceeds 180 milligrams, remember I told you the diabetes is diagnosed when it is 126. Between 99, between 100 and 125 is called pre-diabetes. And that is the one Dr. Khayumi was telling is the one that we haven't diagnosed it, or they have not been tested. So pre-diabetes can lead to diabetes also. So when glucose builds up into the stream, it has to be excreted out. And when it goes out into the urine, then that is where the glucose makes the urine sweet. And that is why the diabetes mellitus word came into existence. So 180 milligrams is the threshold at which the glucose is excreted out in the urine. That threshold goes down in pregnancy, but that is a different discussion. Now, glucose also, when it attaches to the proteins of the body, anywhere in the body, either in the basement membrane of the kidney or in the pericytes of the retina or the endothelial cells of the blood vessels, it causes a sub change called glycosylation. And then that glycosylation causes dysfunction. And that is due to that dysfunction, both in structure and function, and the genes that are associated with it, that causes the complications of diabetes.
So, Irzad, can I ask you the next question? And that is, you clearly explained what diabetes is. It's high blood sugar and high blood sugar levels in the urine. But are there different kinds of diabetes?
Yes, if you could show the next slide, we could discuss that. I think the two major types are called the type 1 and type 2 diabetes. There are other forms of diabetes called secondary diabetes, where the pancreas have to be removed because of cancer or injury or due to surgery. Then that also will make you deficient of insulin. But when we are discussing diabetes in a common way, we discuss of type 1 and type 2 diabetes. In secondary diabetes, where the pancreas are damaged or destroyed or removed, we have to not only supply insulin, but we will have to supply those enzymes that are so essential for digesting food. The proteins, the carbohydrates, and the fats that we eat have to be digested. So we have to supplement not only insulin, but those enzymes also. And that can be done by mouth. Insulin, you have to be given as an injection, or you can inhale insulin. So that is the limiting factor of insulin. So let's go to the types of diabetes now, the common types. 10% of the population would be those with type 1 diabetes. That means that they cannot live without insulin. Before the discovery of insulin in 1921, these people would not survive too long. They would die because of ketoacidosis, a condition where insulin deficiency leads to breakdown of fat and production of ketones. Most of these young type 1 diabetics are of age below the age of 20, but some people have developed type 1 diabetes at a later age also. They are often associated with other autoimmune conditions, particularly hypothyroidism due to Hashimoto's thyroiditis. So that is type 1 diabetes, and they are not usually overweight. Whereas type 2 diabetics are often obese. That means they have an excessive amount of weight related to your height, and they also are older in age, and they have some certain predilection in certain populations, like the native Pima Indians, the South Indian people, and women who give birth to children greater than 10 pounds. These are predisposed people to diabetes. So obesity, weight gain, high BMI, basic metabolic index, and older age group are associated with type 2 diabetes. And they don't completely destroy the insulin, or they have insulin that is inefficient at the where the insulin binds to the receptor. Insulin is like a key that opens the glucose pathway for the glucose to enter into the cell, or where it can function to supply energy either to the brain or the body tissues. And uh, type 2 diabetes is often associated with a very ominous condition called cardiovascular disease or heart disease and the blood vessel disease. It is the small blood vessel disease that really provokes the blindness, the loss of vision, the cataracts, and so forth, and the kidney dysfunction or the failure of the kidney to act as a good filtering mechanism.
So,
go ahead.
Excuse me. So, Dr. Rasu, in summary, then there are two major types of diabetes, type 1 and type 2. Majority of us are going to have type 2. Type 1 people are generally inherited, they are young and thin. The others are probably overweight.
Yes.
The question now is, what are the challenges the body faces when we fast and have diabetes?
When we fast, the body has to get the supply of glucose because the brain and the tissues of the body are constantly using up glucose. So the whole mechanism of fasting is to shift from the stores that the body itself has to supply the glucose. And the first store that it harnesses is the liver. When the liver stores glucose in a form of a molecule called glycogen, it's broken down. And when we fast, the insulin level drops, and therefore the body gets the message to get the glucose into the bloodstream, and it uses these resources. In the first 8 to 12 hours, glycogen supplies the sugar for the brain and the tissues. Thereafter, then we have to use fats as our second source of a supply to make molecules that can eventually be harnessed as energy molecules. So when we are fasting for longer periods, then fat becomes another source of production. These small fasts are actually a stress to the body, but it is an adaptive stress. So it has some very profound advantages. The immune system wakes up, the cluttering of the system of the bodies is getting cleansed, insulin sensitivity increases, and some processes which are long-term benefits to the body is also incurred. So that is a very good thing about a short fasting. I think that was the wisdom why I think we were told to fast, and it is a process and a practice that has been done from a long time, long ago. Even in the Quran, it mentions that which has been done, which we advise you to fast, as it has been done to the past, the previous people before us. So, so fasting for short periods is a great advantage to the body, particularly in obese people who are pre-diabetic, who are wanting to get organized and to curtail the weight. Fasting can be an advantage that way. I hope I've made myself clear in that way.
Yes, thank you very much. So essentially what we're saying is that in a prolonged fast, which is more than a few hours, the body has to make lots of adjustments to make sure that the glucose level is maintained. It does through a variety of hormones that you mentioned. And if you have diabetes and have taken medicines to lower blood sugar, this could be hazardous potentially and needs to be monitored, and that you should talk to your physicians and so on to be able to do that and to recognize what the symptoms are when the sugar levels are too low, so-called hypoglycemia, and also recognize by testing when the sugar levels are too high or hyperglycemia. So thank you very much, and we'll move on to the next set of questions that I had for Dr. Shahid Qayyumi. So say that I have diabetes. Should I really be fasting during Ramadan? And what are the criteria for safety for a person with diabetes to be fasting? Shahid.
So obviously, it's a personal decision whether you can fast during Ramadan, but I think basic principles, anyone who's medically sick from any severe disease should not be fasting, because this can be dangerous to your health, not just patients with poorly controlled diabetes. So however, our topic today is mainly about diabetes. So you may be exempt from fasting if you're sick or your blood sugar levels are very high, or so you should really discuss it with your healthcare provider. It's hard to provide definite advice because everyone is an individual and all doctors practice medicine very differently. So this is just a general guideline. It's not specific for anyone in particular. One important thing is if you do check your finger stick or do continuous glucose monitoring, that does not break your fast. So you can go for blood testing and so forth, because it doesn't involve ingesting food or drink.
I think you need to go back.
Yeah,
okay.
I think.
Okay, that one. Go ahead.
So I think
Sorry,
this
this
slide,
is set as auto. Give me 1 second. I'm just trying to control it.
This is fine. Let's go with this.
Yes.
So if you are at very high risk, fasting is not recommended. So if you've had a lot of low blood sugar reactions within 3 months prior to Ramadan, or your blood sugars are consistently very high, say above 300 milligrams per deciliter, and you have the 3-monthly average, which is the hemoglobin A1C, that should be running less than 7 ideally. But if it's greater than 10, you most likely are not going to, it may be unsafe for you to fast. So you're having a lot of low blood sugars, and or you've had high blood sugar crises, diabetic ketoacidosis, hyperosmolar state, which is when your blood sugar is very high within 3 months. If you're sick from any severe illness. Also, if you're a manual laborer and have diabetes, this might not be the best thing because you may be at risk of severe low blood sugar reactions. Definitely not during pregnancy, kidney failure on dialysis, and people with cognitive deficits, so dementia should not be fasting. So we've defined patients at high risk, patients whose hemoglobin A1C levels are between 8 to 10%, where their sugars are moderately high, may choose not to fast. Usually, these individuals may have microvascular complications, as Dr. Isakharastu said, so eye disease, kidney disease, or disease of the large blood vessels, such as heart disease, stroke, and so forth. They may not be good candidates to fast safely. Or if you're living alone and you're treated with insulin or sulfonylureas. Sulfonylureas are glyburide, glimepiride, and glipizide in America. And patients who are just medically sick from heart failure, stroke, cancer, kidney disease, or very elderly should not be fasting as a general rule. However, if your diabetes is fairly well controlled, your hemoglobin A1C level is less than 8, and you're not taking any major medications that can cause low blood sugar, it may be safe for you to fast. So, and you have no major diabetes complications. Also, people at low risk are people who are fairly healthy. They just diet control diabetes or taking medications such as metformin, pioglitazone, and generally weekly non-insulin injections such as Trulicity and so forth. They're not at risk of low blood sugar. Their diabetes is well controlled, and it is going to be safe for them to fast.
So, Shahid, you have mentioned that people can be on a variety of different medications and so on, and the levels of sugar are important criteria to determine who is safe in terms of fasting with diabetes. Also, we've said that the associated conditions such as heart disease or kidney disease, etc., may influence the safety. But, and we will come to diet in a minute, but what about people with diabetes who are taking all these different medicines, including insulin? What should they do with their medicines? And what should they do in terms of changing the doses, and what should they do with insulin dosing? So I know there are millions of medicines, or at least several classes of medicines, and it's a long thing to go through, but very broadly, if you could go through these, because this would be of great interest to people with diabetes who are called, who's listening in. Thank you.
So there are a lot of diabetes medications which are anti-hyperglycemic. So even medical professionals, many doctors are not aware that a lot of diabetes medicines are used for other diseases. For instance, metformin is used for infertility and polycystic ovary syndrome in non-diabetics. So does not cause low blood sugar. So all the anti-hyperglycemic agents do not cause low blood sugar and would most likely be safe to take. And you could most likely have a safe Ramadan fasting experience. So one of the most commonest drug, obviously, for type 2 diabetes is metformin. Generally given once or twice a day, depending on the formulation. So if it's once a day, you can take it with iftar. Twice a day, you can take it with iftar and sahri or suhoor. 3 times a day, you can maybe take the lunchtime dosage with your iftar. So to split it to just make it twice a day. If you're on slow release metformin, take it at iftar. So SGLT2 inhibitors, a long name, but basically these medications such as Jardiance and Farxiga and Steglatro, what they do is they prevent sugar absorption by the kidney. So again, they don't cause low blood sugar as such on their own. However, the unusual aspect of these medications is that if your blood sugar is very high, they will work regardless, and you may get dehydrated. That you do need to drink a lot of fluid. So really you need to be established on these medications, and your blood sugar needs to be fairly well controlled for you not to get dehydrated. So that's like a unusual, maybe possible side effect from that class of medications. Then we have the GLP-1 receptor agonists. So these are non-insulin injections. Again, some of them are FDA approved for weight loss. So again, do not cause low blood sugar because you can use it for obesity, generally off-label, but anyway. So again, they do not cause low blood sugar, so they're safe to take. Mostly people use weekly injections, so it's easy to do. So long as you, again, established on themselves, the major side effects are nausea, vomiting, and diarrhea, constipation, things like that. So assuming you're stable on it and it's not causing these side effects, they would be safe to take. I think we move on to the next slide. So DPP-4 inhibitors such as Januvia, Tradjenta, and alogliptin, again, they only do not cause low blood sugars. So they increase the amount of digestive enzymes in the body. GLP-1 levels go up slightly with these medications. So again, no low blood sugar, safe to give, can be taken anytime, morning or evening. The only thiazolene dialone available in this country is pioglitazone. Again, that can also be used for infertility, does not cause low blood sugar on its own. So can be taken once a day, either with iftar or suhoor. Mostly, patients should be stabilized on all their diabetes medications before they go into Ramadan. So there shouldn't be a need to add a lot of new medicines in case of side effects. You can always take medicines away during Ramadan, of course. So the one class of medicines to be careful of, obviously, insulin and sulfonylureas. So the commonest ones used in this country are glipizide, glimepiride, and glyburide. So they can cause low blood sugar. Even the short-acting ones can be quite long-acting. So if you're taking it once a day, take it with iftar. If you're taking it twice a day, maybe reduce the morning dosage by half. So take half your usual dosage of glipizide or glimepiride in the morning with suhoor. And if you are having low blood sugar, consider reducing and or stopping the sulfonylureas. Then we have, I don't think we have a slide on that, but insulin. So many different types of insulin. So there are long-acting insulins such as Lantus and Tresiba and Toujeo and Basaglar and so forth. They're generally given once or twice a day. Most likely no adjustments need to be made for that. Some people are taking insulin mixtures such as 70-30, 75-25 insulin. They can be taken twice a day, again with iftar and suhoor. Doses may need to be adjusted. But actually a lot of people during Ramadan gain weight and their blood sugar levels go up. So not everyone is having low blood sugars during Ramadan. Everyone has an individual problem. And then there are fast-acting insulins that are taken with meals. So they can be taken with iftar and suhoor, and obviously there's no lunch, so you won't be taking that. I would say need to be really careful if you have type 1 diabetes to, I mean, personally, I would advise against it. although there are many people that I know, my own patients, who have successfully fasted with type 1 diabetes and have not had any problems.
Thank you. Just to summarize what you have said, most of these agents are safe to take because they do not cause excessively low sugar levels, hypoglycemia, except when you come to sulfonylureas. These are the glipizide, glyburide, glimepiride type of drugs, where the dose may have to be altered and care taken more. Some of the long-acting insulins, no need to adjust dose, except for short-acting ones where you'd have to titrate the dose. But talk to your physicians specifically of how to handle these things is the message. Okay, we will move on to some thoughts about diet and exercise. Kiran, you want to carry on?
Yes. So our next set of questions are for Dr. Wahida Karamali. She is an expert in nutrition, and she has advised good suggestions in the past, and we'll ask her a few more questions based on that. So, Sister Wahida, as far as diet is concerned, what would you advise a person with diabetes to do that is different?
Can we get on to my slides, please?
Yes.
This is the wrong slide set.
Okay, hold on.
But you can start, Dr. Karmali.
I don't see the slides.
They will be bringing it on.
Okay. Assalamu alaikum. Thank you so much for your introduction, Kiran. And I think now we're going to get into the part where you can have control over what you eat. Once your healthcare provider, being a primary care physician or your endocrinologist or your cardiologist, has made some adjustments in your medications, now you have to be in charge of your health in terms of lifestyle modifications. So to begin with, we have to, well, where are we? Is this my first slide? Okay. Okay, you can go back. Okay. Okay, and just to add to what Dr. Fayumi already said about what's in the Holy Quran, also chapter 20, verse 81 says, "Eat of the good and wholesome things that we have provided for your sustenance, but indulge in no excess therein." And that's a good statement for regardless of whether we have diabetes or any other health issues that require modifications in your eating patterns, or even just to stay healthy. So, of course, the essential part of being spiritual is that we are grateful and thankful for the food we eat. Next slide, please. So, as the two physicians said, we have to sort of reset for Ramadan. And as part of the resetting is to make sure you see an individual who has the credentials to provide medical nutrition therapy. And that individual is a registered dietitian nutritionist, and also can be a certified diabetes educator who also has this additional credential of being a registered dietitian nutritionist. You know, there are a lot of people who call themselves nutritionists, but just because you eat, you cannot become a nutritionist. So just be aware that you see a person with the right credentials so that you can discuss a proper nutrition plan. And it requires the patient's participation, because that will help to improve your diabetes management when you're fasting. And as Dr. Shahid said, you know, there is an increase in weight. So we need to adjust caloric intake for weight management, and also to make sure you're getting all the nutrients you need. You don't have to be deficient in protein or in calcium or in iron. So you make sure you do all that. And also you have to think of all the past experience in terms of when your blood sugar was low and you were hypoglycemic, or when it was too high and you had to even stop fasting because your blood sugar was over 300 milligrams per deciliter. And we have to continue with some kind of exercise, physical activity, but it also has to be limited and also the best time when you can actually exercise. Next slide, please. So while we are managing your blood glucose levels, think of all the other risk factors that you may have. About 66% of the patients who have diabetes have high blood pressure, and practically all patients with diabetes have one or more lipid problems, cholesterol problems. So the desirable goal for triglycerides, which is fat in your blood, is less than 150 milligrams per deciliter. The HDL for men should be greater than 40, and for women greater than 50. This is considered to be the good cholesterol, but don't get hung up too much on it because there is a lot of new information on HDL. And just because you have a high HDL may not be very protective, because there could be mutations that could be actually harmful. But focus on the LDL cholesterol, the low density lipoprotein, which for patients with diabetes is recommended that they should have less than 70 milligrams per deciliter or even lower. And the blood pressure has to be monitored carefully. The systolic being less than 120 millimeters mercury, and diastolic of less than 80 millimeters mercury. Another important thing, particularly for us South Asians, is to watch your waist circumference. Our waist circumference has to be lower than the other people, like the Caucasians or Hispanic or even Black people. We have to have our waist circumferences have to be much lower because we have more body fat. So even if I compare myself with a Caucasian and we have the same BMI, which is related to your body weight and your height. And even if you have the same BMI, I would have more body fat, which would make me more insulin resistant. And that's why South Asians have a high prevalence rate of diabetes. And in sort of India is considered to be the diabetes capital of the world. So need to watch out. And we are really trying to get South Asians aware that even if your BMI is greater than 23, you should get screened for diabetes. And hopefully you will, even if you're talking to a doctor, hopefully that your physician brings that up and talks about diabetes in your family and looking at your body weight, so to prevent you from getting to pre-diabetes or even full-fledged diabetes. And of course, we need your fasting blood sugar to be less than 100 milligrams per deciliter. So when it comes to nutrition intervention, it has to be tailored or prescribed for each individual, depending on what medications you take, what type of insulin, looking at your lipid levels, which is the cholesterol levels, and also if you have any other medical conditions or metabolic outcomes. Next slide, please. So there are some very good diets that have been actually examined very carefully in clinical trials, which means they're very carefully controlled with arms of placebos and the diet itself. One of them is the DASH diet, which is an acronym for Dietary Approaches to Stop Hypertension. And this diet emphasizes fruits and vegetables of different colors, whole grains, smaller amounts of protein foods, the meats, chicken without skin, fish, including more plant-based proteins like the lentils, the different legumes, including soy. And as we go up the pyramid, you'll see less and less of the foods that you should be on your plate. So the foundation, again, as you see, is the vegetables and fruits, followed by the whole grains. And the Mediterranean diet is also very well studied. And as you see, what do you see there in that picture? Lots of color, lots of vegetables, lots of fruits. You also don't see beef steaks and lamb chops, but you see a little bit of chicken, you see fish, and you see this tall bottle of extra virgin olive oil. So why do you think this diet, I'm sort of focusing so much on the Mediterranean diet? Because it has been shown to reduce coronary heart disease very significantly, like from 29 to 69%, and also the risk of stroke by 13 to 53%. And we have studies, long-term studies that look at patients over years, and those are called prospective studies. And people who follow the Mediterranean diet is associated with 20 to 23% reduction in developing type 2 diabetes. And the very controlled trials have shown that you can lower your hemoglobin A1C by about 0.5%, and also it reduces your risk for heart disease, the cardiovascular disease, by like 20 to 30%. So how does it all work? When you have these fruits and vegetables of different colors, they are like powerhouses of antioxidants. So there are anti-inflammatory, antioxidative. You have this raging fire in your body, so you have to put out the fire. The only way you can do it is by having these different colored vegetables in your diet. So the diet itself is during fasting is no different from when you're not fasting. You have to have balanced meals from iftar to suhoor, and you have to make sure you drink a lot of fluids, not sodas with sugar in it or juices, but you should have just water. Of course, you can add some lemon juice to it and make it interesting, add some mint to it. That also is a very exotic way of including water in your diet. And you have to distribute your carbohydrate, which means all those foods like the rice, the whole wheat products like chapatis or naans, etc., including even the lentils have carbohydrate in them, but they also have protein in them. So you have to distribute it sort of equally, and I'll tell you how to do that. And also be aware of if you have high blood pressure or you have any cholesterol problems, and also your weight problem, if you have a weight problem. So what we are recommending is once you know how many calories you need, you can have about 1/3 of the calories for suhoor and about half of it for iftar. But if you're planning to have snacks, again, you can have 1 or 2, and you can have a small percentage, like 10 to 20% of the calories for these different snacks. Next slide, please. So you have to sort of divide your calories between your suhoor and iftar with your snacks. So sort of don't worry too much about these percentages. You need to look at your plate and make sure half your plate, most of it is vegetables of different colors. So hopefully your doctor has told you when you look at your plate, make sure it's filled with different colored vegetables. So when you go shopping, okay, they have told me to buy, doesn't matter if it's a white vegetable or a green or a yellow or orange vegetable, but make sure I have a lot of it, a little bit of fruit, and a quarter of your plate with the lean protein, maybe a chicken or maybe fish, or even if you're having tofu, that could be, it's a very good quality protein. It's very similar to beef protein in terms of the amino acids it has. So it's really good to include as a plant-based protein. And the rest of it could be green, but it has to be whole grain. It has to be brown rice, quinoa, which is an Andean grain, which is also high in protein. It's a fabulous way of including a grain in your diet. So oats are great. Oats are always whole grain. So if you see a product which says wheat bread, it doesn't mean it's whole wheat. It just means it is wheat. So it's very important for you to look at the ingredient label. Make sure the first ingredient on your label says whole wheat, or it says oats, or it says quinoa, or it says brown rice. All that is good. Watch out for the kinds of fats you have, because if butter and ghee, they are loaded with saturated fats. Coconut oil is loaded with saturated fat. So if you're going to have even a like a pina colada without the alcohol in it, which I had, which was available last evening at an event I was at, it's like having a heart attack in a glass, because the coconut oil is so high in saturated fat, it's over 90%. So watch for that, and watch for all the fried foods. Everybody loves to eat pakoras and samosas, but they are full of fat, and they're not really going to give you any nutrients other than fat and some refined carbohydrates in it, unless you have pakoras that are baked and they are made with chickpea flour, and can have some spinach in it or some onions, and that would make it a little bit a better quality product for iftar. And if you have to use oil, use extra virgin olive oil, or you can also use soybean oil, canola oil, corn oil. They're all unsaturated oils. Okay, we have gone to our next slide, which is just talking about eating large portions during iftar. Will also be problematic. It can raise your blood glucose, and also you may be eating too many calories that will have an effect on your body weight. And keep your highly processed foods like white bread or pita bread made with white flour, or your chapatis made with white flour. Not too much of it, but you have to get to using whole grain. And it's good for all of us, for your children. Make sure they also learn to eat in a wholesome way, starting very early in life. We are seeing a lot of patients, who have diabetes, particularly with liver disease called non-alcoholic fatty liver disease, which are fatty streaks in your liver that can progress on to fibrosis and maybe even end up with cancer. So I have seen little children who are chubby, kind of look cute, run around looking cute, but they have fatty liver disease very early in life because they have gained too much weight. They spend too much time in front of the screen, not getting enough exercise, drinking a lot of sugary products with fructose in it, like the high fructose corn syrup. So watch out for these products, which are not good for you during Ramadan or any other time.
Thank you so
Dr.
much,
Khan.
Sister Wahida. Our next question for you is that when should people with diabetes be testing their blood sugars?
Okay. It's what's recommended, and this comes from the Diabetes Research and Clinical Practice group, which have a wonderful resource for you to look at, is actually almost like 6 times a day or any extra time. It could be the pre-dawn meal, during the day, midday, mid-afternoon, pre-sunset meal, 2 hours after iftar. You have to be comfortable with it. How often? Discuss it with your physician before Ramadan, so that you can get into doing it and checking your blood sugar and reporting back to your physician to see how you're doing. So, but these are the recommendations from this group. Next slide, please.
This is great. Based on this, we have a new question. So, and if it's okay with Dr. Arshad Kayumi, we can open the Q&A session. Because the audience has sent out a few questions and asked about, couple of people have asked about continuous glucose monitoring devices and how to manage those during Ramadan. So we'll open the floor to all the experts. Dr. Kayumi.
Dr. Kayumi, you want to take it?
Continuous glucose monitors will be very useful. I mean, they have alarms if you have the more sophisticated ones to tell you that you're about to have low blood sugar or the blood sugar is going up very high. So safety wise, especially patients taking insulin and especially type 1 diabetes or pancreatic diabetes, ideally should be using that. And it will make the whole, fasting during Ramadan really safe. So I would definitely recommend it. I mean, not everyone obviously has access or financial resources and insurance for it, but if you have availability, it would be very useful.
Yeah, I think I just like to add to it, you get to look at time and range. And if your blood sugar is going to be less than 70, you need to break your fast. And if it's over 300, you need to break your fast. So, if you're in good time and range, you have to, be able to discuss. And the nice thing about it is you can have it uploaded to your physician or your diabetes educator, and they can help you too to manage your diabetes.
There are another question for Dr. Karmali is what fruits are recommended for diabetic patient? And the second is jawar roti better than wheat roti?
Yeah, if you eat whole wheat or a jawar or bajra or whatever, they're great. They're high in fiber, and you can have a combination of them. Yes, please go ahead and have it, but don't put ghee and butter on it. Use extra virgin olive oil and enjoy it with that. As in terms of fruit, there are a variety of fruit. I would prefer berries because they end up with less calories. So if you have half a cup of strawberries or half a cup of blueberries, they'll give you around 15 grams of carbohydrate. Bananas, I see huge bananas in the market. So if you're going to take a third of a banana, or if it's a sort of a medium-sized banana, half a banana is fine. If you have sort of half of a medium-sized apple, that's like one fruit. So you have to be careful in terms of fruit is not, it's not a free lunch. You can't have as much as you want. 12 grapes is like 15 grams of carbohydrate. So you have to discuss this with the nutritionist or your diabetes educator or your physician to know how many fruits you can have. So in terms of the portions, there are what's called the fruit exchange list that sort of gives you an idea how much fruit you can have to give you 15 grams of carbohydrate. And then you can decide whether you want to have like 3 fruits or you want to have 4 fruits. And that can be managed, but you can't be drinking glasses of juice. That I don't recommend to anyone, because you rather have the whole fruit because there is fiber in it, and that will be helpful in managing your diabetes.
There's a question about exercise. How much and what time of day and what kind of exercise would be recommended? Okay.
So with exercise, you have to continue to doing it, but do something that you would enjoy, like walking. Nothing very strenuous. Don't do weightlifting or running. But I think the best time is like 2 hours after iftar would be a time that I would recommend that's kind of safe. You don't want to do during the day. You don't want to get hypoglycemic. So best time is after you've eaten, wait for a couple of hours and then do your walking or get a bike at home and exercise or dance or whatever you want, but do it after iftar, like a couple of hours after iftar.
Thank you. If there are any other questions, people can unmute and ask them directly.
About that home glucose monitoring, I was thinking that it is such a useful device that even though insurance may not cover, or even though it may not be used throughout the entire month of Ramzan, just the beginning of the Ramzan for a 10-day period or a 14-day period, depending on the monitoring device that you're using, is a very powerful and a useful tool, not only for the physician, not only for the researcher, but also for the patient in terms of preventive care and also alerting them. Even that little bit of information is very profound. Sometimes a sample from a physician's office might do the trick. Sometimes an extra expense might have to be incurred, but it's a very powerful, and it's a sea change in the way in which diabetics are being followed and treated. So I think it is a great advantage.
Okay.
So I would also like to add that, don't have your suhoor too early, because you don't want to get hypoglycemic during the day, and make sure you do eat your 2 meals, and don't try to just say I'm going to sleep through and just have a huge iftar and a couple of snacks, because you're going to get hypoglycemic throughout the night, and that could be problematic during the day, and you may kind of plunge and get hypoglycemic. So it's really important to make sure you eat both meals and maybe 1 or 2 snacks if you feel like it at night.
Thank you very much. This was truly excellent, and I'd like to thank our expert panel once again for doing this so well in such a short time, and apologize for rushing everything. But I think the message that you gave was truly instructional, and I hope it will help people living with diabetes as well as others in terms of how they should handle this condition, which, as I said, is increasing, especially in the South Asian community, astronomically, almost in epidemic proportions. So in ending, I'd like to remind all of you that this is a service of Imamia Medics International, and this is through the Academic Council, and the speakers here are part of that. The IMI is a vast organization, as you know, providing healthcare services, humanitarian relief, professional development, community service, advocacy, and so on. Do become members if you are not so already. Participate in any way of shape or form as you can. This discussion will be on YouTube, available on the IMI website. It'll also be on IMI TV, and will be available throughout this period. And so if people ask you about this, you can recommend this in your communities to them, because I think it's truly valuable. Reach out to us through email or through the webpage with questions and suggestions, any other topics, etc., that you want us to cover, either during Ramadan or afterwards. We would be happy to do so. Once again, I thank everybody, and have a great rest of the Sunday. And Ramzan Mubarak.
Thank you. Ramzan Mubarak.
Mubarak.
Thank you very much.
Thank you very much.
Thank you. Great panel.
Thank you.
Thank you.
I think that went very well. Thank you, Shahed, Ishaq Bhai, Wahida, Sister Wahida.
We're going to have lunch.
While you can. We won't be able to do this next weekend. Okay. I think it's worth doing it before Ramadan, of course, so people become more prepared. So I think generally we have done this later in the season, but this was well timed.
Do a pre-Ramzan, like what we are encouraged patients to do, to visit the doctor 3 months beforehand, and then
we probably should do it even earlier than we are doing it currently. Absolutely.
Just before Ramzan, just as a reminder.
Right. I think we'll make it as an item on the calendar. Thank you very much. And if you can suggest other topics that would be of interest to the general public, we'll be happy to set this further.
As you said before, when we met, we are teaching the medical education upside down. So I think we should correct it by little sessions of preventive medicine. I think that would be so useful. Travel, diet, nutrition, exercise.
Right.
Little things that could modify the people's life.
Right. That
Psychological
Dr. Karmali is important for that kind of thing, right? Because on the medical side, we sort of take that for granted. Don't have time.
psychology and the physical lifestyle changes.
Right.
That is.
Good.